Hi, this is Martin Gutenberger. I will be going over how to go through a PE protocol chest CT. First I'll point out what we usually do as part of our PE protocol. You will get the axial images with the PE protocol. You will get maximum intensity projections both in the coronal and sagittal reconstructions, and then you'll also just get regular coronal and sagittal reconstructions. Some of our scanners also will show you the bolus tracker, which is what they use to time the dose, and then we also get our scout images. Start off just by looking at the scout images. Some of it is because there's a larger field of view than you'll get on your CT, so you might miss something important in the upper abdomen or in the arms. So look at those briefly, and then the other reason to look at it is just to get practice kind of with a low quality chest x-ray, trying to make findings on that before you go to the CT. After I've done that, I switch to my axial CT images, and I do my usual chest CT search pattern. I'm going to go through it briefly here. If you want a little bit more depth, go to the just the routine chest CT search pattern video. First, I look at the axillary lymph nodes. This patient does have a few axillary lymph nodes on either side. I look at the thyroid, supraclavicular nodes, and then I move down through the mediastinum, looking for lymph nodes there. Look by the esophagus. One thing I haven't mentioned before is I usually am also looking at the anterior chest wall while I'm on soft tissue windows and posterior chest wall musculature as well. After I've finished looking at the mediastinum, the chest wall, then I switch to looking at the heart. Since this is a PE study, part of that search is that I will look at the pulmonary arteries. Part of doing a PE study is you have to decide what your sensitivity for PE is likely going to be. Part of that is how good the bolus timing is, and part of that has to do with respiratory motion. If they have poor bolus timing, you might miss small emboli, and if they're breathing, you might miss small emboli. So if you think that the pulmonary artery is not well opacified, you might measure an ROI, a Hounsfield units, over the pulmonary artery. This person is great, 396. We'll go down to 180 or 200 before we start worrying that the sensitivity might be low. At that point, I just pick a side. Usually I start on the right, and I follow down to the lower lobe pulmonary arteries, and then I'm just kind of looking at the pulmonary arteries as they all branch off. I'm looking for any sort of filling defect within the pulmonary arteries. Then I come back up, and I'm following some of these arteries back up, and then I look at the middle lobe pulmonary arteries on the right, and then I switch to the upper lobe pulmonary arteries on the right. Most of them, the large vessels are going to be in this area, and so part of it is kind of like looking for nodules, where you're kind of just scanning the larger area for abnormalities. Once you get to the smaller vessels, when you're in the larger vessels, you're kind of just looking at that one vessel or the couple vessels that are in a area for anything big. After I've done the right side, then I do the left side. I do the left lower lobe first, and then I do some of the lingular arteries here, and then I switch to the left upper lobe. After I've finished looking at all of those, then I'll be done looking at the pulmonary artery on these axial images, but I will come back to it on the maximum intensity projections. I finished looking at the hard and great vessels. You'll get variable opacification of the aorta, but it's worth looking if they're having chest pain. Make sure it doesn't seem like they're having a dissection or anything. And then I look at the heart, and this person actually has hypertrophic obstructive cardiomyopathy. You can see how thick their left ventricle is, and that's why they have this subcutaneous ICD over here. Then I switch to the pleura and to the pericardium. Just look for any thickening or effusion, and then I'm ready to look at the lungs. And just like on all my other chest CTs, I look at the anterior right lung first, going down, and then the posterior right lung going up, and the anterior left lung going down, and then posterior left lung going up, which I'm doing quickly here just since I'm going through this just to show you what I do. After I'm done with that, I switch to my liver windows. I look at my liver in the upper abdomen, and I switch just to my regular upper abdomen windows, and I look at my spleen, pancreas, adrenal glands, and kidneys, at least what I can see of them in the upper abdomen. Once I've finished that, I'll switch to bone windows. I'll scroll up on the bones and look at the spine first, and then I'll look at the shoulders and ribs next. Depending on whether the indication is hypoxia or chest pain, which are usually your indications for a PE, you'll have different things that you're looking for. If the indication is chest pain, I'll take a little bit more time looking for rib fractures. Be extra careful just because that could be the cause of the chest pain. If it's for hypoxia, I'll spend more time, or I'll have a higher threshold to call things in the lungs, like maybe ground glass opacities or anything like that that might be explaining their hypoxia. After I've done that, I'm kind of done with my axials, and I'm ready to switch to the different reconstructions. I look at the coronal MIPS next, which I find to be really helpful for laying out the vessels, looking for PEs. I like to window it, and I like to do this on the axial as well when looking at the pulmonary artery. So the pulmonary artery isn't as bright white as possible, but that is just slightly less than completely bright white. I do the right one first, and you can see on the MIP how it lays out long segments of the arteries. Now, because it's a maximum intensity projection, if there was a tiny little embolus, you might miss it in here, but generally that's not the case, and these really can help you look at long segments of the pulmonary arteries at once. And some of these arteries, where you're only getting a little cross-section of it on the axials, seeing a long chunk of it makes it more obvious that there's an embolism in these arteries. So I'll do the right side first, and then the left side, and then I'm done with my coronal MIPS. And then I just switch to my sagittal images through the chest, look at the bones again, look at the spine, and then I'm done with my PE protocol chest CT.